I think C-arm techniques and technology, sort of the benefit of C-arm has been that you get to see the anatomy. You get to verify your instrument position. We kind of talk about robotics and surgery, and I think part of the problem with a robot is the robot isn't as good as a human yet. I mean, Elon Musk has kind of figured that out, and that human gets immediate feedback from what's going on. And I think as total joint surgeons, the benefit of fluoroscopy was we got an additional point of feedback. We got feedback from fluoro and our own sense of how things should be. I think anybody in this room who's done a couple hundred anterior hips has an idea how the instruments fit, how the cup goes in, and that you're not, the fluoro kind of confirms for me now that I'm right, but I don't do a lot of changes with the fluoro so much anymore, all right? I think one of the things that always comes up when you're teaching courses has been somebody comes to me with a pre-op film, a fluoro film, and their post-op film, and their fluoro film and their post-op film don't look the same. It's probably not happened to anybody in this room, but there's always somebody that comes and says, I don't even use fluoro anymore because when I use the fluoro image, it doesn't match my post-op image. And part of it is it's a restricted worldview, so I think that was the push to go to 12-inch from 9-inch C-arms. But every single time we change something, there's sort of unintended consequences. When you go from a 9-inch to a 12-inch C-arm, you get more pincushion distortion, you get more S distortion, and you get more parallax because the field of view is bigger, so the incident angle of the particle to the receiver is changed more so than it would be with a 9-inch. So the other piece is, it's sort of, there's another person in the room who's not a surgeon who's moving something to help you. So I always push with GE, I was lean on those guys, and starting about 10 years ago, saying, the thing that needs to be a robot in this room is the C-arm needs to be a robot. If the C-arm was smart and I could simply ask it, or the tech could come in and set it up, and then I could give it voice commands and it would always go back to those images, and there was some consistency of image capture, that would be good. And whether you're doing pelvic surgery or acetabular surgery or total joint surgery with a fluoro, the biggest struggle we have is we don't consistently see the same image all the time. It's got to be derotated or re-rotated, moved around. And it slows the workflow of the case, and total joint surgeons are not exactly the most patient group. So as an inpatient cohort of individuals, we tend to maybe bend the rules a little bit and then wonder why we don't quite get what we want. So this started for us as the overlay technique. I liked it. It was interesting, but it was also sort of cumbersome, and it kind of went against my own trauma. I don't mind drawing once, but I have a plan, but I don't like to sit there and get dirty and retouch and do things. So I didn't really love it. And then even when we would go to trace, if you're cheating with the 12-inch, sometimes the tracing doesn't quite fit, and you don't know why the tracing doesn't fit. It wasn't until later that I kind of figured that out. But so we went away from this to some kind of reference point in the field, and with that reference point, then I could adjust my limb lengths and my cup position from a known reference point. So the first problem we have with the C-arm is that parallax occurs. So my hand hasn't necessarily changed position, but my apparent view of my hand has changed. So it looks like a line here and it looks like a surface here, but the hand hasn't necessarily changed position. What's happened is the incident angle of the light coming to my eye has changed. So it's the same as like I'd be driving and I'm doing 80, and my wife looks over and she's like looking at me like you're only driving 75. It's actually the other way around. She's driving and I think she's driving slow, and I'm sitting in the passenger seat going, why are you driving 75? And she's really on the speedometer driving 80, 85. So if you're impatient and you use the 12-inch and you shoot right in the middle of the pelvis, and you make assumptions about the shape of your cup position, then you're also getting heavily influenced by parallax. So the counter to that is to go and center on the teardrop or center on the cup when you actually evaluate cup position, and then slide back to the middle when you're evaluating leg lengths. This has more to do with a single particle generator in a wide receiver, right? And so CT would avoid this, but right now we don't have a single shot sort of CT thing. So the other distortion that we get is that sort of Mercator map position distortion or pincushion distortion, and that happens in the older C-arms, which there are, I think, about 700,000 in the world, but it's a dome-shaped image receiver that's then projected out flat. So you get distortion around the edges of your image, which has to do with the inevitable distortion of taking a curved surface and making it flat. It's the reason why Alaska is so big and Texas is so small. I'm from Alaska, so it's a little bit funny when you see Alaska like as big as Russia, but it's really not. So the one that I think is the real brain twister is S distortion, which is electromagnetic distortion. And this is the one that I think has tripped me up, particularly in room 9 at University of Utah. We would be doing a case in the morning. And think about what happens in the morning in Utah in the summer, right? It's cool in the morning. We're doing a case in the morning, and there's not a lot of distortion in the image. If you're nailing a tibia in room 9, that tibial nail looks pretty straight. If at around 11 o'clock, 12 o'clock, all of a sudden that distortion in the nail would get very pronounced. The distortion on the total hip would get quite pronounced. And I'd be like, we've been using the same thing all day. Is it bent now? And then what I realized was, what would happen about that time in the morning is they would turn the AC unit on. And so the AC unit power conduit, which is this like 50,000 amp power conduit, goes right below OR9. And there's a huge EM field that starts when they flip the air conditioning on. So I'm going to show you, but that EM distortion, that S distortion that occurs, happens worse when somebody turns on their cell phone and has a talk, when the air conditioning's turned on. In certain shielded rooms, it's not very much. And in other rooms, I'll show you some data, the other rooms, it was much worse than that. So starting quite a long time ago, in the early 90s, people said, you got to be really careful when using fluoro for navigation because there's distortion. And until we can correct this distortion, you can't trust the imaging. So I would ask, then it's sort of one of those things, does it matter? So you look at this and you're like, I don't know, I sort of eyeball it. I need some reference line because I'm not very good at, drawing a straight line. So I draw a straight line off the inferior ischium, and you can argue this is correct, this is not correct, do it at teardrop, do it at ischium, et cetera. But we'd look at this, and those of us who would draw the line, and I'm not going to get in an argument about which is the best line to draw. I'm just going to show you that that looks short on the operative side, correct? We can take that. So now we've put into the field a known axis system, and in that system, it looks bent, right? It looks bent much like the S distortion pattern or that EM distortion pattern. We don't recognize it on this image because everything's a curve. And so unless there's a straight line for us to see in our eye that looks bent, we don't know what it is. Everything looks like a curve in the pelvis. It's what makes the pelvis fun, is that it's a collection of curves. But when you put this axis system in, all of a sudden the system is bent. And if you looked at the inferior line here, if you trace this line across from that point on the lesser, and you came all the way across to this point on the lesser, it looks like it's actually the same length, right? It looks like the surgeon actually got the length correct. And lo and behold, the post-op film, the length is correct, whether evaluated off the teardrop or off the ischium. And what we were really seeing here was about 1.5 centimeters of S distortion. So this is that OR9 with the power conduit turned on, okay? And so you can reveal it inside the field of view, right? So here, you can again see that A line looks like it's lining up on the inferior, the lesser tuberosities. It looks pretty much right, but a straight line drawn across the ischium is off, okay? Again, kind of repeat this, not to beat it to death too much, but again, the post-op film, you assume you take that as correct and you go ahead and your lengths are correct, all right? So if I pass through this is now going to be some backfield correction. So if I play this video, first you see that's the image, everything looks okay. You could argue cup position looks a little bit maybe not as anteverted as I would like. We can't, it's just one side, so we're not going to make a comment about offset. Then we're going to play this, and in playing this, it paints the distortion into the image, right? So that's the actual distortion of the image. We're not trying to, and that's it back corrected to normal. So there's a certain amount of effect that goes on when you back correct that image back to normal, okay? Which, when you're doing pilons, and you talk to people who get really finicky about pilons, or you're doing total ankles, that becomes a real problem. Because in a pilon, particularly when doing a total ankle, it's allowed you about 3 degrees of variation in your valgus varus in a total ankle before you end up having failure, mechanical failure. And the distortion in a pilon is about 7 to 8 degrees from S distortion. So it's in the realm of a potential failure for your fixation. So here, tracing, so we do a tracing, we do a teardrop tracing. We pass this through. So that's with the distortion. And then we'll do another tracing with the distortion corrected, so that's the yellow. And then we'll flip the overlay. Once you flip the overlay, we'll match the teardrops by dragging the teardrops down and matching the teardrops. And you'll get to see that there is an apparent leg length difference that's just based on distortion. We haven't changed the components, we haven't moved the components. So here we move that down to correct to the teardrop. And you see you've essentially made the limb longer, but you really didn't change anything. It's just what you thought wasn't quite what you thought. It's the same sort of effect. I was thinking of a good metaphor for this. So space travel. If you assume that light isn't bent by gravity and you travel through space and you're going to go 1,000 light years somewhere, but that target that you're supposed to get to after all this time traveled is not where you think it is, because it's actually the light that came from that object has been bent by these gravitational fields on the way to the point that you saw it. When you get out there, you may find yourself thousands of light years off course from where you're supposed to be and lost. So if we don't understand that there's some distortion going on, and there are multiple ways that you can compensate for this, and I think we all do to some degree, but if you don't recognize that it's there, you're going to accept some error in your navigation, right? So I kind of think of this as if you're flying an airplane or you're running a fishing boat, and you're going to go through some place that's dangerous. I want dead reckoning, I want GPS, and I want radar. And you're like, well, if I have a good GPS, why do I care about the radar? The radar gives me real-time information about what's going on. If the GPS fails, I'm actually going to be there. Dead reckoning can be wrong and can be right because of just your own sense of perception and your fatigue. So when you do dangerous things, I think you should have a multiple fail-safes so that you get the expected outcome at the end. So. Again, this one you would assume operative side short. There's some distortion here. When you correct back, you realize that distortion, that your perceived sense of shortness, your length, or was actually your error in assuming that this world that you were looking at was actually orthogonal, and in fact it's bent. So we look at this. This is a study that Gilliland, who is my junior, was my resident at the time and was my partner and is now a colleague. But we looked at ones done with just a rigid grid, and we had pretty good results. I think everybody kind of knows this. Then they came back, and they simply looked at positioning. They went back, and they went back and looked at all the ones that we had done, and they just measured out. This is those guys at Utah just measuring out distortion. And what's interesting is that total distortion mean was 10 millimeters from right to left on a 12-inch centered in the middle of the pelvis. And what was really disturbing to me was that in one of the cases, it was 20 centimeters. It was 20 millimeters of distortion. So if you said, hey, I'm okay if I'm 1.5, if you're like a traditional posterior hip surgeon and you're okay being a little bit long, and you said, I'm going to make this long, you would have added length to somebody who was already 2 centimeters off. So potentially at the end, you would have added almost 3.5 centimeters to this person. And that's the one that's only 2.7 millimeters, I don't really care about. It's the outliers, it's the wing nuts. And the wing nuts are the ones that make your clinic painful. They're the unexpected outcome that shows up in clinic, and you don't understand why the fluoro image and the final image aren't making sense. And if I could take that away from one person's life, it's worth it. If I can take it away from every person's life so that they don't have that wing nut one, then I feel like we would have made a contribution. So in 25 images taken, you're talking about a mean total distortion of about 10 millimeters left to right, and you're talking about one person who's 20 millimeters off, which is disturbing to me. So anyway, you can do this analog, you can do this digital, either way. You can do it with a metal rod, you can do it with chicken wire, there are many ways to get around it, but the main purpose of this was to express that there is multiple kinds of distortion occurring, and that image that we see is not as accurate as we would think, and I would strongly encourage everyone to have some way to back compensate for that. Thanks.